already touched on the prioritization a little bit. We couldn't get away from it. And we're going to start with Dr. Lauren Bellin, who, again, has an amazing historical perspective on this. And I already told them, if some of you were listening before we officially started, when I was a medical student starting to think about these issues, I did agree in economics. And then when I kind of, was thinking about ophthalmology, I started reading. I'm pretty sure Lauren Bellin's paper was the first thing I read. And that's where I feel indebted to him for being one of the pioneers in this area in Canada, thinking about it, working. I think he actually does a lot of oculoplastics, but still is just trying to help us out on the cataract surgery side. So without further ado, we're going to let him give his talk. And the title of his talk is, sorry, I just lost my, Cataract Surgery Prioritization Waiting List, the Manitoba Experience. Go ahead.
Okay, thanks. Can you see my screen right now? See my slideshow? Yeah, good. Okay, so thanks for inviting me to share my experience that I've had in my province. I'm also going to share some national experiences, and some of these are more about the sort of politics related to cataract surgery over the years, because I've been dealing with this for the last 30 years. And as I give my talk, I hope you will appreciate why I chose this old movie poster as the theme for my talk. I think it will become somewhat apparent. So first of all, I have no financial disclosures about this talk. So in the early 90s in Manitoba, we were facing a crisis with regards to wait times for cataract surgery. We had a split. We had most surgeons, we had a split between surgeons who did subspecialty work and those who did purely cataract surgery. So the surgeons who did subspecialty work, such as myself and others who also did some cataract work, had relatively short waiting lists for cataract surgery, but those who were just the pure cataract surgeons had much longer waits, and many of these waits were were a long time over a year. This led to the introduction of a couple of private surgery centers in the province where people would pay $1,000 in order to jump the queue. And while this was very popular with the people who had that money, there was widespread condemnation when this was reported in the press because it was felt to be violating the Canada Health Act. And ultimately, the government decided that they couldn't tolerate this. And so what they did was they bought all of the time at the private centers and then put it back into the public queue. So the numbers of cataract surgeries were exploding around this time in the developing world. And mostly, I think it was partly population demographics, and then it was also the advent of better, safer technology. And so this increase was taking place. A major concern arose right at the outset, which what we're talking about right now, is whether cases were appropriate or inappropriate. So one of the earliest studies to look at this was sponsored by the NIH in the United States. And they funded this study called the Port Research Study. And so this was a study that looked at outcomes comparing cataract surgery in the United States, in Manitoba, in Denmark, and in Spain. And so I was one of the two ophthalmologists in the Port study from Manitoba. And this was one of the first studies where Snellen acuity was identified as not being the best predictor of what was going on with patients' subjective satisfaction with their vision or how much they might gain after successful cataract surgery. And so this VF14 was developed, and it was basically just, we had a much longer subset of questions, but when the statistical analysis was undertaken, it was identified that these 14 questions were best at predicting how much patients were going to complain about their vision and how much they were going to gain from cataract surgery. But really a key point to remember is that it didn't really identify everybody. And in fact, in the Port study itself, there were 10% of patients who had VF14 scores suggesting that there was no problem at all, and yet they were undergoing surgery, and there was no indication or sense that this was inappropriate surgery at that time. So following the development of the VF14, in Manitoba, we were realizing that we had really long and unacceptable waiting lists, and we needed something to introduce prioritization. So after the port study, we held a departmental meeting to create a standardized scoring system to fix the problem. So the first element, excuse me, was the VF14, but people felt that that was not enough, and that we needed other factors to be taken into account. There was a feeling that extra points needed to be awarded if work or driving for work was threatened because of poor vision, and also loss of a driver's license was felt to be a significant concern. Also, I guess to a degree related to the lengths of, oops, sorry, I went back forward. There was a concern that people might be getting bumped over and over again if other people with higher priority came forward. And so it was decided that there should be some also credit for how long you were waiting on the system. There was also concern that the whole system might be gamed by ophthalmologists who wanted to create longer waiting lists in order to get more operating room time. And so ultimately it was decided to create a central program that would be run at the Misericordia Health Center, where most of the cataract surgery was being done, and that all of the scoring would be done by the staff at Misericordia, and then reported back to the respective surgeons for them to use to plan their slates so that they couldn't introduce any degree of bias to this. So we put the system into place in 1999. And once it was in place, it very rapidly accomplished its target goal. And patients with greater morbidity ended up having shorter wait times, as seen here. Still pretty darn long. Also, it had a similar effect in reducing the wait times for people who were out of work because of correctable visual impairment, and the same pattern was seen for patients who were loss of or risk of losing their driver's license. One of the benefits of the introduction of this system was that we could see that there did not appear to be changes in thresholds for surgery by surgeons over time, in that the VF14 profile stayed approximately the same from year to year. We also saw that the thresholds for booking surgeries were actually quite similar from surgeon to surgeon. The number of annual cataract surgeries in Manitoba has always been capped by the government, and this data helped us to convince the provincial government to increase our annual allotment of cases. Another interesting finding that I'd certainly never seen reported before was that there was changes in individual surgeons' length of waiting lists over time. Prior to this study, it's certainly been my presumption that the relative length of waiting lists was somewhat static, and that people with long lists tended to stay having long lists. But as you can see from this comparison between a 5-year stretch, there can be substantial fluctuations in the relative lengths of waiting lists for different surgeons. So we continue to operate with this system. But wait lists, were a big issue across the country, and the government ended up funding some national research projects to try and tackle the problem. And one of them that was mentioned at the start was the Western Canada Waitlist Project. And this project involved representatives from BC, Alberta, Manitoba, and Saskatchewan. And a prioritization tool was developed in this project. And one of the key components of the tool was a subjective severity score that's in question 7 at the bottom of the page here, where the surgeon would tick off on a line from not urgent at all to extremely urgent where they saw the patient's priority. And at the time, I argued quite strongly that our central system in Manitoba was better because the prioritization ranking was determined by independent hospital staff and couldn't be gained by the surgeons. Within the actual project itself, we agreed to undertake a comparison between the two ranking systems, and much to my chagrin, ultimately concluded that the results of the scoring systems were virtually the same. So I didn't think our VF14 system was that much better. We still continue to operate it. As has already been alluded to, a villain as far as ophthalmologists are concerned arose, and this is a picture of Dr. Ken Wright. And he wrote the paper that's been quoted where he argued that up to 1/3 of patients undergoing cataract surgery didn't need the procedure. And this was based on using the VF14, and he was looking at the scores and saying that there were just too many patients who had scores that were too low and shouldn't be done. And as was mentioned, the politicians just lapped this up because they were looking for ways to cut costs, and limiting surgery seemed like a very attractive model. So we were able to use our Manitoba system to try and combat this misinformation, because what we did was we undertook a project in Manitoba where we specifically looked at patients who reported no symptoms on the VF14 score, who were waiting for surgery, and then interviewed them again, actually twice, before and after surgery, to find out why they agreed to be on a surgical waiting list if they said they had no symptoms, and then subsequently to find out how much they felt that they had improved from undergoing surgery. And what we found in the study was that there was fallacy in Professor Wright's arguments. And we found that there was no statistically significant difference in the satisfaction rates between the patients with the VF14 scores of 0 and those with higher scores. And this highlighted the fact that the VF14 was a useful tool for prioritization, but it was not intended as a threshold device for determining whether or not surgery was indicated. So in 2004, Prime Minister Stephen Harper announced the federal government's intention to try and tackle wait times works within the provinces, and that he was going to work with the provinces to solve this problem. Part of the plan was to create panels that would develop the benchmarks for the 5 priority areas. At that time, I was the chair of the Canadian Ophthalmological Society Council on Provincial Affairs, which was a discussion group that met twice a year with representatives from each province to simply discuss what issues were current across the country. And honestly, for the most part, was just a talking session about relationships between ophthalmology and optometry. But I decided that this group would be an ideal body to actually preempt what the federal and provincial governments were doing and try to come up with a recommended benchmark that was created by ophthalmologists, not created by bureaucrats. So I conducted a literature review at that time, and I really was very disappointed to find that there was almost nothing in the literature about outcomes. And we saw those slides earlier in the first presentation, how little there was in the literature about outcomes relative to wait times for cataract surgery. And so there really wasn't much factual basis on which to establish a recommended benchmark. Probably the strongest, the one study that I remember from that time was from the United States, where people were in a center where people were waiting over a year, and they took a small cohort and prioritized them to have their surgery within a month and showed that it was advantageous. But that really didn't help establish, what was a logical benchmark. Personally, the only study that seemed relevant to me in trying to figure out where an appropriate benchmark would be was a study that was done by Dr. Carolyn DeCoster and myself, which looked at Manitoba claims data to see what the incidence of documented falls and fractures was over time after patients had been put on the waiting list for cataract surgery. And as you can see from the data, really the only logical time to undertake surgery, if your goal is to eliminate unnecessary falls and fractures, would be to do the surgery the next day. I mean, there just is no rational sort of break point at which it makes sense. About a year prior to this, I guess it would have been around 2003, the Swedish government had come up with a waitlist guarantee for cataract surgery and specified that all surgery should be done within 3 months of booking the procedure. And then a few weeks prior to this meeting of the committee that I was chairing, a report came out from Sweden indicating that the government was failing in its attempt to meet the 3-month guarantee because of generalized logistical problems. And so this led me to recommend to my committee that we should instead set the benchmark for 4 months or 16 weeks because it seemed like hopefully it was going to be a doable target, an achievable target. So this was unanimously achieved by the rest of the approved by the rest of the committee, and this became the official COS policy. So that's actually the origin of where 16 weeks comes from. Once this was nationally publicized, this was generally adopted as the official benchmark. Although interestingly, in Ontario, they ended up deciding that 6 months should be the benchmark. However, subsequent reporting nationally still generally uses the 16-week for comparisons. So The federal government designated 5 priority areas for wait times. There were waits for CT and MRI scans, waits for hip and knee surgery, waits for cancer care consultation, waits for cataract surgery labeled as sight restoration, and wait for coronary artery bypass. The 5 areas, the 5 affected national specialty society, along with the Canadian Medical Association, agreed to join together and form a new group called the Wait Time Alliance to monitor the effects of wait times in these areas. I was initially elected by the COS to be the ophthalmology representative on the Wait Time Alliance, and then subsequently elected by the WTA members to be the Wait Times Alliance chair. We ended up creating report cards that came out a few times a year to sort of tell the public what was going on with this. And this is one of the early report cards that we created. And you can see that under the SR, or site restoration, the Manitoba was actually doing pretty good near the beginning. We scored a B because our initial wait times were not too far off the benchmark, and the green color represents what the trend was over time, and so we were trending in the right direction. So it was actually looking pretty good. Unfortunately, that didn't last. Around the time that this happened, the Misericordia Health Center quietly gave up the cataract prioritization system that it had because it was expensive to run. Because we had to have this staff maintaining this central database and phoning every single patient. And our wait times had become relatively short at that point. So the question was it really making that much of a difference? The hospital administrators argued that when wait times were down to almost 4 months, does it really make sense to spend a lot of money just so that a higher priority patient gets done at 3 months versus the 4 months? So they dropped the system. But as we've seen before, demographics reared its head and started to cause us problems. The Manitoba, Manitoba kept the same total number of funded cases, but our population demographics started to shift like it has for every other province. So this slide shows Statistics Canada's data on people over 65 in green. And since most patients have the most quoted average age for cataract surgery is 72 to 74, it was obvious from this data that there was going to be a surge in demand. But when we asked to raise the cap on the number of annual surgeries, we were turned down. The federal provincial accord that led to the Wait Time Alliance finished in 2015, and basically the federal government stopped all further interest in the area. And so this issue has, for the most part, dropped from the national scene. However, wait times continued to significantly deteriorate in Manitoba. Rather than offer to fund more cases to shorten the waits, the Ministry of Health started to push for the creation of a single queue entry system for cataract surgery so that all patients would wait the same amount of time. The ophthalmologists and the optometrists in the province were very opposed to this because it would remove autonomy and would end long-established working relationships. We agreed to try and develop a system that would, where a monthly report would go to all optometrists advising them on how long the wait was for a consult for each ophthalmologist, and then how long their wait was till surgery could be done. And then the optometrist had to declare in writing that they had given their patients the option to going to an ophthalmologist with a shorter waiting list if they chose instead to refer to someone whose wait list was 1 standard deviation or more longer than the average. This was effective in bringing down the variance in our wait times between surgeries to the point that the ministry backed off in the idea of having a central queue at that time. However, in 2017, the government created a new wait time reduction task force. You'll hear me say this over and over again. And this task force concluded that Manitoba had now had the longest waits for cataract surgery in the country, ranking 10th out of the 10 provinces. And one of the things that the task force was pushing for again was the creation of a single queue because that had been established in orthopedic surgery. And this was sort of the poster child system for the government. At that time, the orthopedics people actually briefly, I had to present it at this task force, as did orthopedics. And so therefore I had access to their data that otherwise I wouldn't have seen. And I was able to negate this push for us to have a single queue, because I was able to show that the variance in the wait time for orthopedic surgery between surgeons was actually greater than the variance for cataract patients with different cataract surgeons. And it's because although they claimed that the orthopedic system was a single queue, it really wasn't, because any patient who had a pre-existing relationship with an orthopedic surgeon could stay with that surgeon, and that was enough to throw out the variance of the whole system. So the aging of the baby boomers has taken a toll on the wait time for cataract surgery in all provinces. Rates of meeting the benchmark have declined across the country. This CAI report from 2021 shows that Manitoba remains one of the worst provinces. Another interesting thing to note on this table is that CAI has undertaken an effort in recent years to try and make all the provinces not look so bad by, instead of highlighting the original benchmark, they now talk about how close provinces are to achieving a 90% rate of the benchmark, implying that this would be good enough. COVID initially made the achievement of the benchmarks far worse for all Canadian jurisdictions, but in the last 1 to 2 years, there's been an effort to try and catch up. In Manitoba, there's been an influx of new money on a short-term basis as we've tried to recover from COVID and catch up. Yet another task force has been created that has provided funding for thousands of new cases on a one-time basis. Unfortunately, they allocated almost all of that money to private surgery centers where only the most straightforward and least complex cases were being done. So this has actually had a disproportionate effect in shortening the wait times for healthy younger patients with milder symptoms, but patients with more advanced cataracts have actually been waiting much longer because they're done at the Misericordia Health Center. We've continued to publish this report that goes to optometrists indicating what the wait time for consultation is and what the wait time from consult to surgery is for each surgeon. Unfortunately, in the last 1 to 2 years, it's become very obvious that surgeons' offices are not providing up-to-date information about when patients are starting on their waiting lists. Plus, the information monitoring system provides data on how long people who just completed their surgery. So its information is not up to date and better reflects what the wait times were a year or more ago than what the current situation is to consultation. This has caused the monitoring system to be much less reliable than it initially was when the average lengths were much shorter. When this was discussed at our Provincial Ophthalmology Society meetings, most surgeons said that there isn't a problem with data reporting from their offices, but this doesn't jibe with information we get when we periodically have optometrist offices phone around to find out what the actual wait is for consultation. As a consequence, this has led to renewed calls for a central queue system. And this time, I'm more skeptical that we'll be able to avoid having a centralized system, although I have difficulty imagining how it would work any better than the orthopedic system. Just 2 days ago, our department head sent out an email to surgeons asking for volunteers to work on developing a single queue cataract waiting system. So it remains to be seen what's going to come out of this. But if we don't, as a group, get our house in order, I feel that it's going to be done to us or imposed upon us. So that's some of the history that I wanted to share with you and what the Manitoba experience has been. Thank you very much.
Well, no, thank you for that historic perspective and some real practical issues we all have to face. And I really love the quotes at the end, this concept of taking a proactive approach to this problem. I think we'll try to hold on the questions until after our next talk. It is getting late for our next speaker. So again, all the more kudos as he gets ready to deliver this, and then we will still have enough time, hopefully, for some discussion after. So Conrad, please go ahead. Thank you so much again for joining us. The title of his talk is Prioritization Metrics that Emulate the Surgeon's Assessment of the Impact of Cataract. Thank you.
Thank you very much. If I fall asleep in the middle of the talk, I guess it was too late. Right, so I consider myself a clinician scientist, although I've published 300 papers, so I'm probably more scientist than clinician. But what I really like to do is to use science to solve clinical problems. That's kind of my thing. And look, we have a gold standard for assessing the appropriateness of cataract surgery. It's the clinical acumen of a skilled and experienced cataract surgeon. You all know how to do it. The trouble is that having a cataract surgeon assess everybody and then put them on a list for prioritization is an incredibly ineffective thing. So we have to come up with something more efficient. But it strikes me that the gold standard solution would be to have a process that emulates as best as possible the standard surgical assessment of the severity of cataract and its impact on the person. So I'm going to call that cataract impact, and I'm going to go through what I think is a solution to developing a single value metric of cataract impact that could be used for prioritization. Now, to get to that, we're just going to go briefly through the assessment of the cataract patient and what sort of data you could take from that to include in a model, how we would create the model and test the model. And really, we need to talk about implementation, because I actually think making this model is simple, but I think implementation is where the real challenge lies. So you don't need me to tell you how to assess a cataract patient. And look, just to be clear, we're not talking about the private system where you need a pulse, a breath, a lens, and insurance, or better still, cash. I love Zoom conferences because I can be in Toronto when I'm in Adelaide, but I hate them because I can't hear you all laughing uproariously at that gag. I'll just have to assume you did because it makes me feel good. We're talking about assessment of cataract patients at the population level. As has been discussed, we have the same problem in Australia you guys have there. We've got way too many people with cataract. We've got more than twice as many people over 65 now as we had when I started 30 years ago. We got more than 5 times as many people over 90. Yet we do no more cataract operations in the public system than we did back then. Right? So we don't have enough resources. The third-party payer, who's the government for this public cataract surgery, is not doing more surgery. So we'd like to convince them to do more operations, but they're allergic to that. But we need prioritization methods so we get the right people to have the operation. So overviewing cataract assessment, we all know what we do, but let's just talk about it in detail, right? You're going to talk to the patient and you're going to establish that they're having problems due to their vision. Typically problems performing activities, activity limitations, or loss of functioning, or what I'm going to call visual disability. Then you're going to measure vision somehow, usually visual acuity, and you want vision to be impaired. And the more vision is impaired, as Aman said, the more comfortable you're feeling about them needing an operation. You're going to look at the lens on the slit lamp, aren't you? You're going to diagnose a cataract. You're going to take into account everything else to do with the eye. You're going to comprehensively assess them, identify comorbidity, and if it's there, you're going to make some sort of judgment about the potential vision for if you take that cataract out. And you're going to pull all that together with your clinical acumen and make a judgment about the benefit of cataract surgery. And of course, you're also going to ask the patient if they're willing to have it. Of course, we know that it's the optics of the eye that affect the vision, and the vision then affects the person. But these aren't one-to-one relationships, and that's because optics is really common. There's 3 age-related types of cataract. At the ultrastructural level, they're all different. They affect light waves and photons striking the lens differently. Vision loss is different. And of course, you have mixed cataracts. So, you can't just look at the cataract or measure the optics. You've got to measure the vision. And you can't just measure the vision because people are different. People are even more complex than lenses and the complexity of vision in how they respond and what they'll tolerate, what they can cope with, what tasks they do, so on and so forth. So you also need to ask the person. Now, you all know this, but these are the 3 key things that we need if we're going to understand how a person's affected. Now, everyone on this conference is good at having conversations with the patient, taking a history, establishing visual disability. You probably have a bunch of go-to questions that you ask when you're talking about cataract, maybe questions about glare, driving at night, driving towards sunlight, and so on and so forth. You want to know about specific tasks. You can all do that. You know how to establish people are having trouble. But as we've discussed a lot, there are also questionnaires or PROMs. And, these are typically lists of tasks that people have trouble doing. And these usually have ordinal values assigned to them, and you can score people's answers, and you can come up with a metric to quantify the trouble people are having with their vision. So there's informal assessment, and then there's formal assessment. And so this could be data that goes into a metric. The same for cataract. I'm sure most people here who, when they're assessing cataract, may record the type of cataract. They may even use some sort of description of whether it's mild, moderate, severe, or the 4+ system or whatever. But we have more formal measurement like LOX3. LOX3 has been around for 30 years, used properly with standard photographs and careful interpolation between the standards. It's pretty good as a metric of cataract. So again, you could formally measure cataract and use that in a prioritization schema. Of course, you can measure vision, and mostly for most people that'll be visual acuity, preferably logMAR. If you've got logMAR visual acuity, you've got something that sits on an interval scale and can be statistically used and incorporated into some sort of numerical metric. Of course, we all know cataract's more complicated than that, and visual acuity doesn't well describe the impact of cataract. Cataracts do lots of things optically. They absorb light, they induce wavefront aberrations, but chiefly they cause forward light scatter, particularly PSC. And so this reduces the contrast at the retinal level, which makes contrast sensitivity testing, and particularly testing under glare, even with a rudimentary setup like this, with a Pelly-Robson on the wall and a bright light shining back at the patient, you can very easily discriminate between people with normal clear lenses or pseudophakia from people with cataracts. And all the people in this box plot saw 6/9 or better. So these are people with good visual acuity, and something like a glare test will inform more greatly about the impact of that cataract on the person. But no one really tends to use this now, even though we all know it's a useful thing. Beyond measuring visual disability, cataracts, and vision, there are other considerations, as has been explained. It's important to understand comorbidity and have a judgment about the visual potential. It's important to contemplate people's place in society and whether they are still working or have caring roles or other tasks which make it important for them to have surgery perhaps sooner. And of course, not everyone's willing to have cataract surgery, so that needs to be contemplated in any model. So in summary, you've got key issues here that ordinarily the surgeon would combine in the supercomputer up here using their algorithm, which is clinical acumen, and surgeons can very effectively make decisions about how severely someone is affected by the cataract. And, if given a task of ranking people, could probably very effectively rank people from more affected to less affected. So that exists. And if we want to prioritize people for surgery, why don't we try and emulate that as best as possible? So we could do that if we created a prioritization metric that included as much of that information formally collected as possible. So now we've already seen a lovely illustration of cataract prioritization models, and I think they're very thoughtfully designed. They typically include these sort of things, right? Typically include a measure of vision, maybe a questionnaire, matters of other issues. But scientifically speaking, where they all fall down is the way in which the data is combined. The models may be logical, but if you're just throwing data into a model without any scientifically developed weighting, or just arbitrary weighting or no weighting, you're going to get a lot of noise in the scoring, which is going to wipe out a lot of the detail of your patient ranking. This situation is completely analogous to the problems we see in standard PROMs. And so one of the quality issues when we talk about PROMs is the way they're scored. Now, here's the visual disability assessment in its original 1998 form, and you can see it's got 18 questions, and all questions have the same 4 response options, which are assigned ordinal values. And the patient answers the 18 questions, you add up the 1s, 2s, 3s, and 4s, and you come up with a score. This is standard summary scoring. It's the way things have typically been done historically. The problem with this is all these questions get the same weight in the final result. And that's not appropriate. It's not appropriate because if you look at the questions, you know that some of these tasks are more difficult than others. All right. There's 2 driving questions in that questionnaire, just like in the VF14, 2 driving questions. And we all know driving at night is harder than driving during the day. So a questionnaire should have those appropriately weighted rather than being given the same value. Once they're appropriately weighted, you take that noise out and you're going to have better quality measurement. There's also an issue that exists for the categories, because not at all and a little are not the same distance apart as a little and quite a bit, and so on and so forth. So you need a scientific method for solving that problem. And fortunately, a very simple one exists, which is called Rasch analysis. So in Rasch analysis, you take a large amount of data from lots of people, and the system, the algorithm iteratively looks at the pattern of responses between people, and it can work out which are the hardest tasks and the easiest tasks and the most able people and the least able people, and it can rank them all on an interval scale. And this is really important because then you've got rid of all that noise, you've got an interval scaling, and you can do parametrical statistical analysis. All right, so this is well established. We've been doing this in questionnaires for a long time. This is the method that enabled CatQuest to become the CatQuest 9SF, and so on and so forth. Now, we can apply this same method to a combination of clinical data and questionnaire data. This isn't just for questionnaires. You can use it for all sorts of things. So the key to it is having lots of data from lots of people that's well collected, and you can use it, as I said, to iteratively explore the relationships between variables and work out where they should sit on an interval scale. And once you've got that, you're going to have your persons, your people, ranked on that same interval scale. And so if you take all the measures that you think belong in a cataract assessment, like a measure of vision, a measure of visual disability, a measure of cataract, whatever else you want, and you put them into a Rasch model with lots of people, with data from lots of people with cataract, you can come up with a single value metric of cataract impact that will order those people in terms of how severely they're affected by cataract. So that's what I think we should be doing. And it could be simple. It could be as simple as the hybrid model, so-called hybrid model explained earlier, of VA and a PROM. But let's face it, you know, no cataract surgeon is just going to do VA in a prom and decide on surgery, right? So it's the more data you include that is more and more like a comprehensive cataract assessment, the better your model is going to be. But of course, the more data you want in, the harder it is to do, the less data, the easier it is to do. So there's a diminishing return, if you like. But look, that's my fundamental idea. A while ago, we tested this theory on some Nike data in collaboration with my good friend Mats Lundstrom, and we looked at 300 people or so who had we had visual acuity on them. We had cataract CatQuest 9 SF scores. We had the pre-Quest questions as well. Pre-Quest is quite neat because it includes these issues of employment or care roles and so on and so forth. And here's the person item map that we generated. This is the same as the cartoon I just showed you for questionnaires. On the left, you've got the people, and on the right, you've got the items that go into the model. And you can see at the top here, you've got people that have suffered the most impact of cataract, and at the bottom, you've got people that have got the least impact of cataract. So the scores that you get here then can be used as your prioritization metric. So if then we compared to, well, we call it first in, first out, or FIFO. You called it something else, but same thing. So typically what happens here in Australia, you know, someone with a relatively mild cataract gets into the hospital system, they'll get an operation before someone with a more severe cataract who gets referred later. I mean, that's just the way it is. So it sounds like it's the same there. So what we found, if we compared to people who are prioritized by that that Nike, that RASH scaled Nike system, we found that more than 3/4 of them, of 300, shifted by 50 rank positions. So, you know, there was a really large reorganization of people into those that were more affected and less affected. So I think this illustrates how dramatic you can improve the order of doing people compared to a first in, first out kind of a model. So just a simple graphic of that. I don't like categories because by definition, all of these things are continuous. You're creating continuous variables. There really will be no natural categories, but for what it's worth, just to illustrate it, instead of people being done in you know, mild, moderate, and severe at the same time, you could move all your severes up and do them sooner. So look, the model's pretty simple. If you've got good clinical data and someone that can run the analysis, you can have a cataract impact model. But it's really all about how you get the data and how you implement it and how that's compatible with your health system. I think this is the whole challenge. Now, going back a while, most of my work on this has really been single site, hospital based, you know, running a cataract clinic myself, seeing patients, collecting data, accumulating it for a while, running an analysis, ordering them, saying, let's do this order. That doesn't achieve a lot because, you know, they're already in the hospital. I think the real solution to all this is community-based implementation. But that's difficult, right? It's easy in the hospital. You have a small number of assessors. You can collect, you can be clear about what data you're collecting. You can collect it well. You get a new ophthalmology trainee. You can train them up to collect the data properly. You know, if you've got a single site or 1 or 2 rooms, you can have glare testing. You can have quite complex models if you want. You know, and you can directly talk to the person controlling the list and make things happen. But this has disadvantages. It takes up a lot of space in the hospital. It takes up a lot of time. A lot of surgeons have the attitude, well, you've got a person in the hospital with cataract, let's just take it out. Don't send them away and wait for another one. Let's just get it done. Look, that's okay. I understand that logic, but there are lots of people out there that are worse and we need to get them in. So the problem really is if you're just doing this within the hospital setting, you're doing all this work behind this enormous barrier where there's all these people out in the community that haven't gotten into your hospital. So I don't think that's the answer. I mean, I think really you need a big picture solution here where your data collection and that you use for prioritization happens in the community, presumably at the optometrist level, depending on your jurisdiction and how things work. But if you can do that, you're going to get a lot more access to people, and you're just going to use your hospital resources for people that have already been tested to be bad enough to get to the hospital. But this is a very difficult thing to do. It's very difficult to get large amounts of people in the community to agree to do something. And usually the best way to do that is remuneration, which you probably won't have. You also need a good IT system to collect this data and deliver it. And you're not going to have quality control over the data collected. You're going to struggle to have a complex model. That may not be a problem. I mean, having, maybe just visual acuity, a questionnaire and cataract score, a cataract grade would be enough. I think this is such a big problem. It needs an ambitious solution, and I think we live in a world of IT solutions now, where really we ought to be looking at, these sort of data collecting implementations that enable prioritization that are just part of the routine referral, rather than people sending in ad hoc letters. Anyway, look, I think there's obviously globally, there's opportunities for implementation. As I said, IT solutions ought to be making this easier. I think RASH gives us a very neat solution to create these models, but I'm sure that there are other ways to do it. And obviously the hot thing these days is artificial intelligence, and there probably is an AI way to prioritize people for cataract surgery as well. And maybe that's something interesting someone will do in the near future. Thank you.
Oh, thank you so much. I wish there was an actual audience. You would have received a standing ovation for that, for everything you do. So you're getting a virtual ovation now, and I'm sure you would have gotten some laughs as well along the line. Oh, I do. Someone is putting in, someone's clapping somehow. It is working on Zoom, so I don't know if you can see it or not. But thank you so much for that. Thank you for putting that all together and for all your work in this area. I do love the idea of, you kind of asserted that we have an appropriateness criteria, which is a skilled surgeon. I don't know if other stakeholders see it that way anymore. But that has been the standard. Many patients just ask us, say, listen, you're the surgeon, you've been doing this for a number of, what do you think? And your idea of trying to incorporate clinical measures into the prioritization, I don't think should be overlooked. I think, as you said, there's a trade-off between the complexity and putting it together in a model. RASH analysis. I wish she was here. Anna Kabanovsky is one of our trainees who did not have a strong statistical background, but really learned how to do RASH analysis well, and really drove. She would be here. She had a great excuse. I think she just had a baby a couple of days ago, or she would be here. But it shows that this is usable for us. And as you said, Conrad, maybe there is a better way now with AI that could be coming. But RASH analysis, I love how you threw all of those inputs into the same model. And as you said, it seems like a very natural way for us to do prioritization, to at least develop an analytical approach. And then, of course, for a clinical rollout, we'll have to, you have to figure out what's actually feasible, which I think, your quote, "devil in the details" is often the issue. So I'll open up the floor here. I do see we had Amandeep, who's been able to join as well. So feel free to comment, or any of our panelists, if they'd like to comment on anything related to prioritization.
Sure, maybe I'll make a comment. Thank you for this great meeting. I'd like to thank everyone for such insightful talks and congratulate Matt and his team for this pioneering meeting. I think there's obviously a huge need for this discussion, whether provincially, nationally, or internationally. I just want to double down on the idea that I think wait time data is very important because it clearly drives decision making, and it also makes for great headlines. The wait time data is a type of quick snippet that the media loves to use as well. But I'm learning that, and this is going to be an Ontario specific comment, but I'm sure it applies elsewhere, but I'm learning that wait time data is not always very clean in our province. And that's true of both cataracts as well as other ophthalmology procedures and medicine in general. And, that lends itself to some trouble. For example, in the cataract space, there's some gaming of the system because we have wait time 1 and we have wait time 2. And really, patients only care about the total wait time from referral to the day of surgery. And I think the idea that perhaps we start this data collection at the optometrist office, which means the clock starts ticking immediately at the time of referral, with a province-wide IT system can help clean that up. It'll minimize the opportunity for gaming there. The other comment I will make is I think we all agree that you need good data to make good decisions, but sometimes you encounter people who are okay with bad data because it supports their political agenda. And I've been seeing that a little bit of that, with respect to moving cataract surgeons in this province. So I know it's a monumental task, but I really urge everyone to make sure that we constantly push to have the cleanest data possible to make the best decisions possible. Because if we have bad data, it's really one of those things where I think it's garbage in, garbage out, and we all know that, but we may not always be dealing with people who want to have that clean solution, whereas maybe perhaps they just have they'd rather have a conclusion that supports their agenda. So just wanted to put those thoughts out there as a frontline worker. So nonetheless, thank you everyone for the great talks this morning, and congratulations, Matt, for a great meeting.
Amandeep, if I can just comment, Matt, I think those are excellent points, but it's interesting to see how hard it is to get that data. And in fact, there is a strong move to ensure that we get wait time 1 and 2 out, because that's really critical that both of those are available. One of the things that the waitlist strategy that Lauren talked about, one of the positive things that came out of that was a requirement for wait time 2 to be listed. We had to put all patients on a list that allowed a calculation of wait time 2. And we've all seen the resistance in Ontario to producing that kind of data, and the feeling that this is just added burden on surgeons to have to do this kind of step that gives us this data. You can imagine the added burden that would be felt by everyone who refers for wait time 1. But I think our electronic and IT strategies will be able to refine that. So data is critical. It's amazing how much the system is being played up till now. And I think getting accurate wait 1 and 2 is going to help a lot. Thank you.
Yeah, thank you, Sharif, for saying that. I think, a few comments. And first is just a reminder that tomorrow we're actually going to have a talk specifically on wait times and some of the work that we're trying to do this at a big data level. That's going to be Sean Bambra, 10:35 tomorrow. So reminder that we're gonna go through some of this tomorrow. And I also don't want to overlook wait time 0, which we're not talking a lot about in this meeting. This concept that there's people sitting with really bad cataracts that are not on any waiting list, and we need to get them on wait time 1. I think Sharif's idea of I said, and Amandeep said it, the patients don't care about this wait time 1 versus wait time 2. They just care about the wait time. And so we really, that should be the measure. And I do think it's on all of us, including working with our optometry colleagues, to build wait time 1 in there. I'm just going to say, maybe this is, selfishly as a clinician, I much prefer to have a longer wait time 1 than a longer wait time 2. And the reason for that is once they're on your wait list, then you have this the ethical considerations of prioritization and the administration in your office. Versus if you haven't seen them yet, you kind of don't know, you don't know what the problem is. It's kind of sad. It's sad to say that. I say that as a clinician, not as a researcher. So anyway, let's pick up that conversation tomorrow as well. And thank you for bringing it up. Lauren, you had a comment?
Yeah, I was going to say, when we introduced that system where we worked with the optometrists about they had to declare if they were sending somebody to someone with a very long surgical waiting list, the introduction of that system allowed us to start measuring wait time 1. So we've been reporting on wait time 1 for many years, but it's still this business of garbage in, garbage out, because what we've been finding is that the reporting from the individual ophthalmologist offices has not been consistent about wait time 1. And a couple of things happen. One is that some offices just sort of sit on the documentation and only submit it in batches every once in a blue moon. So their lists change. And then we've also heard cases of people falsifying their wait time 1 data in order to make it look like they are a more attractive surgeon to get referrals. So it's a problem.
Yeah, and we're going to speak to this tomorrow. I'm just at a loss to think why this should be done at the clinician level when we are universal healthcare systems with billing codes that can be tracked universally and in real time. And that's where my hope is that will be a systematic, reproducible approach that can be done at a system level that can, reduce the possibility of gaming, decrease the burden on the offices, and improve consistency. But of course, these are easier said than done. And I said, I hope we can continue that conversation tomorrow. But I do appreciate what you guys have done in Manitoba. I think that's helped us. I do think Ontario is a little bit more complicated because it's a little bit larger. But I think a good way to sometimes study it is go, work in a place that's a little bit smaller, a little bit more bite-sized that you can manage, and then roll that out on some of the more complex systems. So thank you, Lauren, for what you've done, I think, in Manitoba on this.
I was just going to sort of follow up on what you just said and comment that, one of the key parts of it was that, I sat down with the head of optometry and, we worked as a group to come up with the system. And I think that really is key, that often we're working in silos and you can't do it that way. They have to be front and center in the discussions.
Yeah, I think that makes perfect sense. I think Cindy brought it up as well. And I think, I'm sure it's in the same in Manitoba. I think there's, the Toronto problem and the North Bay problem are quite different, probably not unlike the Brandon problem and the Winnipeg problem are different. And the levels of care that optometrists provide in these areas are vastly different. The referrals I get from an optometrist in North Bay is quite different than what I get from an optometrist in Toronto, because there's a whole nother layer of care sometimes in the urban centers, which is, for instance, general ophthalmology in this circumstance. So a lot to parse out, a lot to think about.